Good evening, ladies and gentlemen, classmates and schoolmates, and especially Mr. Laingo. I am Amythes Quipot from BSN 3C, and I am here to report about the thrombocytopenic purpura hemolytic anemia syndrome, pathophysiology. So I have here a diagram of the pathophysiology of thrombotic thrombocytopenic purpura, or the TTP. It is a blood disorder in which platelet clumps form in a small blood vessels. This leads to a low platelet count. And I have here a predisposing factor and precipitating factor. So under the predisposing factor, we have here HIV, pregnancy, cancer, infections, lupus. And under the precipitating factor, we have here lack of activity in the ADAMS13 enzymes or the ADAMS13 deficiency. What triggers the thrombotic thrombocytopenic purpura is the acquired ADAMS13 autobodies, congenital ADAMS13 mutation, which results in ADAMS13 deficiency, and also the pregnancy under the postpartum period, unclear mechanism, and failure to cleave large VWF multimers, and results in the accumulation of large VWF multimers that usually broken down of ADAMS13, which results in platelet aggregation and formation of platelet thrombi. And also in the hemolytic uremic syndrome, it caused by a Shiga toxin of E. coli infection, ADAMS13 inhibition, and the shutdown of complement regulatory genes, which result in uninhibited membrane attack complex and a widespread hemolysis, which result in a platelet aggregation and formation of platelet thrombi. Platelet aggregation and formation of platelet thrombi has three components: the uncontrolled platelet activation and consumption, which results in thrombocytopenia, and it reduces the clotting ability, so it becomes a purpura. So we have also here widespread microthrombi, occluding blood vessels, causing tissue damage or necrosis. It comes along in the central nervous system, which result in confusion, severe headache, focal neurologic findings, and also in the heart, the patronecrosis of the myocardium, arrhythmia, sudden cardiac death. And in the kidney, we have the glomerular damage, GFR, protein leakage into the urine, which causes into proteinuria and acute kidney injury, or AKI. Also, the formation of fibrin strands to the microangiopathy hemolytic anemia, and down to the cellular damage due to fibrin deposit in the intravascular non-autoimmune hemolysis, and the serum indirect bilirubin increases. Also, it increases the serum lactate dehydrogenase, and the serum haptoglobin increases. I have here a informative PowerPoint slide that I will explain more. So thrombotic thrombocytopenic purpura hemolytic anemia syndrome. Thrombotic thrombocytopenic purpura is a rare disorder that causes blood clots, or thrombi, to form in small blood vessels throughout the body. These clots can cause serious medical problems if they block vessels and restrict blood flow to organs such as the brain, kidneys, and the heart. The predisposing factor, as I have mentioned earlier, is HIV, pregnancy, cancer, infections, and lupus. And the precipitating factor is lack of activity in the Adams 13 enzymes or the Adams 13 deficiency. What triggers the thrombotic thrombocytopenic purpura is the acquired Adams 13 autobodies. This one cause when a person's body mistakenly makes antibodies that block the activity of the Adams 13 enzyme. And under the congenital Adams 13 mutation, congenital Adams 13 deficiency is a rare disease that leads to recurrent episodes of thrombotic thrombocytopenic purpura, a case that mimics a recurring immune thrombocytopenic purpura in a child. Mild cases of Adams 13 deficiency may be initially confused with immune thrombocytopenic purpura if hemolytic anemia is not severe and renal or neurologic symptoms are not present. Pregnancy or postpartum, specific proteins found in the placental circulation serve as antigens that trigger maternal antibody production against the Adams 13. Acquired Adams 13 autobodies plus the congenital Adams 13 mutation causes Adams 13 deficiency. Mutation of the Adams 13 gene can be found resulting in significant risk of TTP in pregnancy in affected women. Acquired TTP is postulated to be secondary to viral infection that trigger production of antibodies targeted against Adams 13. Women with acquired TTP also have high risk of recurrence in a subsequent pregnancy. It has been proposed that specific protein found in the placental circulation serves as an antigen that trigger maternal antibody production against Adams 13. As such, TTP associated with pregnancy accounts for 12 to 31% of all cases of TTP and is associated with high rates of obstetric complications. Platelet aggregation and formation of platelet thrombi. Platelet aggregation and thrombus formation at sites of the atherosclerotic plaque. Rupture is a dynamic process that can lead to intermittent or permanent obstruction to blood flow, resulting in ischemic tissue injury and organ dysfunction. So we have here the uncontrolled platelet activation and consumption, which cause into thrombocytopenia. Thrombocytopenia occurs when your blood platelet count is low, and it results in purpura, a rash of purple spots on the skin caused by internal bleeding from small blood vessels. And we have here the widespread of microthrombi occluding blood vessels causing tissue damage necrosis, including the heart, which causes arrhythmia or sudden cardiac death, CNS or central nervous system, which causes confusion, severe headache, focal neurologic findings, and under the kidney would be proteinuria, acute kidney injury, or the AKI. And we have also here the formation of fibrin strands, which also triggers. It is formed by action of the protease thrombin on the fibrinogen, which causes it to polymerize. The polymerized fibrin, together with the platelets, form a hemostatic plug or clot over a wound site. Microorganopathic hemolytic anemia, now used to designate any hemolytic anemia, related to RBC fragmentation occurring in association with small vessels disease. In DIC, RBC fragmentation is thought to result from deposition of fibrin or platelets within the microvasculature. Increase in serum indirect biliverdin, or the total biliverdin minus the direct biliverdin levels in the bloodstream. Increased serum lactate dehydrogenase. It is a condition that causes increased LDH in the blood, including liver disease, heart attack, anemia, muscle trauma, bone fractures, cancers, and infections such as meningitis, encephalitis, and HIV. Increased serum haptoglobin. High haptoglobin levels may be a sign of an inflammatory disease. Inflammatory disease are disorders of the immune system that cause serious health problems such as infection, trauma, inflammation, hepatitis, amyloidosis, collagen diseases, or lymphoma and leukemia, and also obstructive or biliary diseases. I have also included here the clinical manifestation. The petechiae appear when capillaries bleed leakage blood into the skin. Purpura, easy or excessive bruising or purpura is dominant. If bone marrow megakaryocytes cannot increase production and maintain a normal number of circulating platelets, thrombocytopenia and purpura develop. Also, we have here hemorrhage, hemorrhagic bullae on mucous membranes, gingival bleeding, signs of GI bleeding, retinal hemorrhages, and evidence of intracranial hemorrhages with possible neurologic symptoms. The bleeding results from unusual low levels of platelets and the cell that help blood clot. Non-palpable spleen. The prevalence of palpable spleen in patients with ITP is approximately the same as the non-ITP population. Example, 3% in adults and 12% in children. Despite the destruction of platelets by splenic macrophages, the spleen is normally not enlarged. Spontaneous bleeding. Spontaneous bleeding occurs when platelet count is less than 20,000 mm3. Diagnostic assessment for a patient with TTP would be a laboratory studies, isolated thrombocytopenia on a complete blood cell count or CBC is the key laboratory finding. The white blood cell or the WBC count and hemoglobin level typically are normal, unless severe hemorrhage has occurred. On peripheral smear, truly giant platelets suggest congenital thrombocytopenia. And also we have here imaging studies. A CT scan of the head is warranted if concern existing regarding intracranial hemorrhage. A pharmacologic management also includes glucocorticoids. These agents are used to treat idiopathic and acquired autoimmune disorder. They have been shown to increase platelet count in ITP. Blood products also administered of IVIG may temporarily increase platelet counts in some children and adults with TTP. Consider IVIG if the situation requires a rapid temporary rise in platelet count. Also, we have thrombopoietic. These agents directly stimulate bone marrow platelet production. The nursing management we have here first is history. Medication can be a common etiology for including thrombocytopenia, and patients should have their medication carefully reviewed. One study used three distinct methods to document drugs that may be associated with induced immune thrombocytopenia or DITP. Second would be physical examination. Address risk factors for increased bleeding such as GI disease, CNS disease, urologic disease, or active lifestyle as they may determine the aggressiveness of the management. Prevent bleeding. Review laboratory results for coagulation status as appropriate. Platelet count, prothrombin, time international normalized ratio. Activated partially thromboplastin time. Fibrinogen bleeding time, fibrin degradation products, vitamin K, activity coagulation time, and educate at-risk patients and caregivers about precautionary measures to prevent tissue trauma or disruption of the normal clotting mechanism. We have here also prevent the